Okay. No delay.
Test 1, 2. Test YouTube audio check 1, 2. 1, 2.
All right, so you're rolling?
Test 1, 2. 1, 2. Test. Test. Chatting very good. Test. Test. Test 1, 2. Test. Test.
Not that one.
Are you good on audio?
Good on audio?
How's your daughter's coming? Does she know where she wants to go? Joining today's briefing, I'll give a COVID-19 status update for LA County, and my presentation will be followed by an update on monkeypox by Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health. In today's presentation, I'll share our current metrics, a look at LA County's early alert signals, information on influenza, and the importance of immunizations in providing protection from respiratory viruses this fall and winter. So I'll take the first slide, or the next slide. Good. Each week, we do share these trend lines for cases, hospital admissions, and deaths over the recent months. In this figure, the green trend line shows you the 7-day average of the number of cases reported daily, and it's measured using that vertical axis on the left. During the past week, we had an average of 1,285 cases reported per day. This is an 11% decrease from the 7-day average of about 1,440 cases reported last week per day. The 7-day average for the number of daily hospital admissions is shown by the orange line, and that's measured using the vertical axis on the right. This metric, again, continued to decrease with an average of around 76 admissions per day in the past week, 21% decrease from 96 admissions per day last week. The blue line on the slide shows the 7-day average number of deaths reported daily. It's measured also by the axis on the right. It's remained relatively unchanged since midsummer, where it's hovered at about 11 to 14 reported deaths per day. Many of our deaths continue to be among older adults and those in fragile health. We send our deepest condolences and wishes for health and peace to those mourning the loss of a loved one. So far this year, nearly 5,500 residents have lost their lives to COVID, or an average of more than 135 deaths per week, leaving thousands of people to face life without their loved ones. These ongoing deaths do serve as a reminder that there are many in our community that still face higher risk and higher stakes as the virus continues to circulate. Each of us can take common sense measures to protect those who are more vulnerable. Stay home and get tested when you're sick. Get tested before gathering with friends and family that could get severely ill if they get infected. And if in doubt, wearing a mask when indoors with others reduces risk, and it can be an act of great caring. Next slide. We continue to use the CDC's COVID-19 community levels framework to monitor the strain on our healthcare system caused by COVID-19. CDC continues to report LA County as having low COVID-19 community level. This has been for the past 5 weeks. The first metric used to calculate LA County's COVID community level is the weekly case rate. Last week, I noted that because of a change to weekly reporting by the state to CDC, the CDC calculation is slightly behind the LA County calculation. Therefore, we're going to continue to use locally reported data to calculate the case rate. Today, our weekly case rate is 88 cases per 100,000 people. This is a decrease from 98 reported locally just last week. The first of the two hospital metrics is the weekly total of new hospital admissions per 100,000. It's currently reported at 4.9 weekly hospital admissions, and this is a decline from 6.5 that was reported last week. The second hospital metric is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. This was reported at 2.9% this week, slight decline from 3.6% last week. Next slide. I also want to provide an update on COVID-19 early alert signals for LA County. In the past week, there were decreases in 4 of our early alert signals. The weekly case rate in the lowest income areas decreased from 80 to 62. The number of new outbreaks in skilled nursing facilities in the past 7 days decreased from 13 to 11. The number of new outbreaks in TK through grade 12 school classrooms decreased from 12 to 11. And the number of new outbreaks reported per week in settings for people experiencing homelessness decreased from 3 to 2. There was a slight increase in the number of new worksite clusters reported, an increase from 68 to 72. There's been no change in the percent of specimens sequenced that are identified as BA.4.6, nor was there a change in the percent of emergency department encounters classified as COVID-related. Both held steady at about 3% and 4% respectively. Our wastewater metric is still pending this week because developing a single metric that actually reflects the trends in all 4 of the wastewater systems has been challenging. Nonetheless, I'm going to present the data on wastewaters for all 4 sites in a minute. Take the next slide. I don't think these are the latest talking points. I'm just going to go back and use, I might use my written ones. But I'll go to the slide. The Omicron variant, which started to dominate last winter, continues to account for 100% of sequenced specimens. The BA.5 subvariant of Omicron, as shown by the larger bright red sections at the top of each bar, remain the predominant subvariant. In the week that ended September 10th, 93% of all sequenced specimens were BA.5. This is the same as the week before and the week before that. The CDC estimates that across the country, as of the week that ended September 24th, the BA.5 subvariant accounted for 83% of specimens. In Region 9, which includes California, Arizona, Nevada, Hawaii, and all of the U.S. territory in the Pacific Ocean, the BA.5 subvariant is estimated to account for about 91% of sequence specimens for the week that ended September 24th. The relative proportions of other key sublineages we are tracking have changed only slightly, including BA.2.12.1, that's shown by the orange bars. That was slightly under 1% last week. Now it declined almost to 0. BA.4.6 is shown by the yellow bars. It's hovering at around 3%. To date, 30 specimens of BA.2.75 in total have been detected. That's about less than 1% of our sequence specimens for this sublineage. Starting last week, we began tracking a new subvariant called BF.7. So far, 7 sequence specimens in LA County have been determined to be from BF.7. 1 was collected the week of August 6th, 4 were collected the week of August 20th, and 2 were collected the week of September 10th. As a reminder, BF.7 is actually a sublineage of BA.5. Sometimes you can hear this referred to as BA.5.2.1.7. With little change in the composition of the circulating variants, there does not appear to be a new subvariant or sublineage on the immediate horizon capable of crowding out BA.5. While this is no assurance that in the weeks ahead there will not be increases in other strains that may be more immune evasive, the data indicates that the new fall boosters are very well matched to what's circulating now and what may be circulating later this fall. Since BF.7 is a sublineage of BA.5 and BA.4.6 is a sublineage of BA.4, the new fall bivalent booster is expected to provide excellent protection. And now give me a moment to go back here. I'll take the next slide. Should be wastewater. Okay. Although the value for our wastewater early alert metric is still pending, I wanted to share these trends that we're seeing in viral concentration for the 4 wastewater treatment plants performing surveillance. On this slide, we're looking at the average for viral concentrations of all 4 of the wastewater treatment plants from late July to present. This week, we performed additional analysis to kind of smooth out the data. We're learning that we need to do this because wastewater viral concentrations can sometimes rise or drop on a given day without the change reflecting a larger trend. These larger or smaller data points can cause distortions in averages. When we smooth the data, the more extreme highs and lows are actually removed so that we can track the underlying trends more clearly. The 2 large plants by far are the Hyperion water reclamation plant and the Joint Water Pollution Control Plant. That's on the top row. Together, they serve about 7.5 million people in LA County, and they cover a huge area across the county. At the Hyperion plant, viral concentrations declined notably the first half of September, and then they plateaued, and you can see there's been a slight increase in the more recent days. The Joint Water Pollution Control Plant had small decreases throughout much of September. Viral concentration trends in the 2 smaller plants are shown along the bottom. The Lancaster Water Reclamation Plant serves people in Lancaster and Palmdale. Last week, we saw a recent increase in viral concentrations in Lancaster, but once we repeated this analysis with that smoothing technique, it appears instead to just be plateaued. Viral concentrations at the Tapia Water Reclamation Facility, run by the Las Virgenes Municipal Water District and serving people in Calabasas and the surrounding areas, have continued to plateau throughout September, with a possible slight increase again these past few days. While the plateauing in viral concentrations in wastewater may signify that transmission is no longer decreasing, because most of our other alert signals that I just showed you indicate low concern still, we do remain hopeful that transmission is not increasing at this time. However, the plateauing does highlight the need to carefully monitor the other early alert signals to see if there are any additional signs in the next couple of weeks that suggest changes in transmission patterns or illness severity. I'll go on to the next slide. Overall, data from the schools remains encouraging, which is why we're sharing this week. In this figure, the orange bars show the number of clusters reported by schools per week and are measured by the axis on the left. The green and blue bars represent the number of cases and students and staff that are associated with these clusters, and they're measured by the axis on the right. As a reminder, a COVID cluster is when we have 3 or more cases that occurred within 14 days and that appear to be linked to each other. The number of clusters reported by schools increased during August as school districts were opening for the school year. They peaked the week of August 21st to the 27th. Reported clusters have declined each week since then, with 66 clusters reported associated with 344 cases for the week that ended September 24th. I'll take the next slide. We also track outbreaks at schools and youth programs affiliated with schools. These are situations where there is an established transmission at the school or in a school activity. This slide shows the number of new outbreaks in TK through grade 12 school settings and youth programs, both during the summer and up to the week that ended September 24th. Since school districts began opening in August, there have been a total of 56 outbreaks documented in our elementary schools. That's the light purple areas. 18 outbreaks have been associated with youth sports programs. That's the orange color. And these have primarily been among football and volleyball teams. 22 outbreaks have been documented in middle schools. That's the light blue color. And 14 outbreaks have been in high schools, as shown by the dark blue color. You can see that the number of newly confirmed outbreaks peaked for the week that ended August 27th. And then they declined for the next 3 weeks. However, the number of new outbreaks increased again this most recent week, but just by a little bit. It rose from 10 outbreaks opened for the week that ended September 17th to 16 outbreaks that opened during the week that ended September 24th. This increase was primarily driven by an increase in the number of outbreaks in elementary schools. While there are more outbreaks that have occurred in elementary schools, the largest outbreaks are often associated with high schools and extracurricular activities, including sports and social events. Recently, over 85 students were infected after attending a school dance, and 13 students were infected on one football team. Given that the risk of COVID transmission is greater with medium and high contact youth sports, we are recommending that schools and teams take sensible prevention measures to avoid disruptions to their season. The risk of outbreaks in youth sports will actually get higher when we get into the winter and more sports are moving indoors. We do want to thank our many partners at schools who are doing a great deal of essential work to keep students and staff safe, including encouraging vaccination and hosting vaccine clinics, following up on cases and individuals who have been exposed, and working with public health to control and try to stop outbreaks. Next slide. One of the concerns that we have moving into the cooler months is preparing for the possibility that this fall and winter we could experience lots of transmission of both influenza and COVID at the same time. This graph shows the percentage of specimens that tested positive for flu over the last 5 flu seasons. You can see that before the COVID pandemic began, the percentage of specimens that tested positive showed a strong seasonal pattern, with fewer than 5% testing positive during the summer and 20 to 30% or more tested positive during the peak of winter. You can also notice that during the winter of 2020 and 2021, that's the purple line, there was almost no flu. All of the efforts to slow transmission of COVID, including wearing masks, staying home and avoiding crowds, washing our hands more often, are likely to have prevented virtually all flu transmission. The more recent flu season for 2021-22, shown by the dark blue line, is also unusual. Flu cases started to rise a little bit in December. However, this occurred during the start of the Omicron surge, so many people began taking significant precautions. Again, all the efforts to slow COVID transmission had a major impact on the spread of flu. As you can see, there was almost no flu during January and February, which if you look at the previous years, pre-COVID, are the months when we're likely to see a lot of influenza. Once universal masking was relaxed back in March, flu cases rose significantly, leading to an extremely unusual peak in May. You can see on here we've never seen a flu season so far out. It's not clear what this fall and winter will be like. However, because there are fewer masks being worn and there's more intermingling, we're likely to see much more influenza than we've seen in the past 2 years. Next slide. In the past, we've been able to look at the trajectory of influenza in the southern hemisphere to foreshadow what the northern hemisphere may experience. Countries in the southern hemisphere, like Australia, which is what we're showing here, experience their winter and their usual flu season in the middle of the year when we're experiencing summer in the United States. This slide shows the case data for the last 6 flu seasons in Australia. As you can see, the number of flu cases typically surges during the Australian winter, with most cases occurring between June and September. Note that the flu seasons for 2020 and 2021, during the depths of the COVID pandemic, are shown by the light blue and green lines here, and they're essentially flat. Flu cases reported this year in Australia in 2022 are shown by that heavy red line. And as you can see, they experienced a relatively severe flu season, dominated by H3N2, which is what's circulating here. And it also started earlier than usual this year, in late April, and then you can see cases increased sharply. The flu season also ended earlier than usual, with cases trailing off considerably by the end of July. Some scientists are concerned that the low rate of influenza infection during the past few years gave people less chance to develop immunity outside of vaccination. This could mean that there's a larger pool of people, especially children, who may be susceptible to influenza this season. Given the data from Australia, we are preparing for the possibility that flu season could start earlier this year, and we could also see a lot of cases. Next slide. In the last couple of slides, we saw how both flu and COVID infect more people in the winter. There are specific reasons for this seasonal pattern. The shorter days, longer nights, and cooler temperatures of winter lead people to spend more time indoors than outdoors, even here in LA County. Starting around Halloween and lasting through New Year's Eve, families and friends tend to gather more often and travel further to see each other for the holidays. As a result, people spend more time socializing indoors, where respiratory viruses can accumulate more and can jump more easily from person to person, especially if the ventilation is poor. The increases in holiday travel mean that respiratory viruses can travel longer distances, hopscotching across the country and the globe. Another major reason that respiratory diseases like COVID and flu spread more in the winter is related to the weather itself. In recent years, we've all become aware of climate change and the effects of climate change. And we've also learned that warmer air holds more water. The opposite is true as well. Colder air holds less water. As the days get shorter in the winter and the air is cooler, it holds less water on average, and the absolute humidity in the air tends to be lower. Just a quick note, absolute humidity is a measurement of the total amount of water in the air, and it's different than relative humidity, which is what is commonly included in our weather reports. When absolute humidity gets lower, aerosolized droplets containing virus tend to contain less water too. They become smaller, lighter, and they can travel further. The cooler temperature allows the virus to remain viable longer as well. Cooler, drier weather also tends to put more stress on our respiratory systems. Our natural defenses against viruses do not work as well, and our airways become colder and drier, with less blood flow and less ability to clear away the viruses. While there are many studies documenting this higher risk of spread of influenza in the winter, there's also a newly published large study that examined weather and COVID case rates from 455 cities across 20 countries between February and October of 2020. They found that overall, lower temperatures and lower absolute humidity were associated with these higher COVID-19 case rates. This added to the growing body of research that showed that there is a higher risk of respiratory virus spread in the winter. So, as late fall and winter bring more people indoors for gatherings and have more people traveling for the holidays, this is also when the weather allows the flu and SARS-CoV-2 virus particles to linger longer in the air and travel further, potentially infecting airways that have lower defenses. Next slide. We don't know yet what this winter will be like, including how much of a surge in COVID and flu we're likely to have. However, we do know that as the cooler weather sets in and cases rise, risk will increase for some people more than others. People who are older continue to face much greater risk than younger people for severe disease from COVID or flu. The risk of severe disease increases notably for those over age 65 and increases further as a person gets older. Our oldest residents, including so many of our cherished family members, face the highest risk. Risk is also higher for those who are unvaccinated or who are immunocompromised, and for those who have underlying health conditions. And risk is also elevated for those whose work requires them to interact with a lot of people, especially if they're working in locations with poor ventilation. As we prepare for the upcoming holidays, one strategy for reducing risk to those most vulnerable to bad outcomes should they become infected is for everyone, including those at lower risk, to get the COVID bivalent booster and flu vaccination soon. This is because those at lower risk, including children, can easily transmit both flu and COVID to those who are more vulnerable. Next slide. Thankfully, we have a lot of vaccine available. Everyone 6 months and older is eligible for the flu vaccine, and since this is an annual vaccination, we all need to get the flu vaccine this year as we do every other year. You're eligible for the fall COVID bivalent booster if you're 12 and older, and it's been at least 2 months since your last COVID vaccination. It is possible that the COVID bivalent booster will also be available for children ages 5 and older as early as mid-October. With over 7 million people in LA County eligible for the fall COVID bivalent booster, and only about 250,000 residents recently boosted with the new booster, there are lots of us who need to make our plans to get boosted soon. Both the COVID bivalent booster and the flu shot are already widely available at almost all pharmacies. All of our public health centers and vaccination sites already have the COVID bivalent booster, and they'll have the flu shots as well by mid-October after we receive our allotment from the California Department of Public Health. The COVID bivalent booster is completely free, whether you have insurance or not. And flu vaccines are also free in most places, even if you don't have insurance. But it's not everywhere, so be sure to ask if there's going to be an administration fee. You're not required to show anything about immigration status to get a COVID bivalent booster or a flu vaccine. Many have asked us if it's okay to get the COVID bivalent booster and the flu shot at the same time, and the answer is a resounding yes. If you've recently had COVID, you need to wait until you've recovered and met the criteria to leave isolation before you go anywhere, including to go get a booster dose. You could consider delaying getting your COVID booster up to 3 months after you recently had COVID. However, there are no disadvantages to getting the booster dose earlier. In closing, the new tools we have are powerful, but only when we use them. Vaccinations, testing, and therapeutics have vastly changed the pandemic's trajectory and the health outcomes for many. We have an opportunity with the new fall boosters and easy access to testing to reduce transmission of Omicron and hopefully avoid another devastating winter surge. With that, I'll now introduce Dr. Singhal, the Chief Medical Director for LA County's Department of Public Health, to give the update on monkeypox, and after that, as always, we'll take your questions.
Thank you, Dr. Farr. Good afternoon. Today I'll be presenting a situational update, case trends for LA County, and updates on vaccination efforts, including eligibility changes and new CDC data on case rates by vaccination status. I'll take the first slide, please. I'll start with our regular situation update. Over 67,000 monkeypox cases have been reported globally, with nearly 40%, or about 25,500 of those cases reported here in the United States. This includes 4,886 cases in California. As of today, there are 2,023 cases in LA County, in addition to 110 cases reported in Long Beach and 27 cases reported in Pasadena. New cases continue to be primarily among gay and bisexual men and other men who have sex with men, and the median age of cases remains 35 years. There have been 110 cases among PEH, or persons experiencing homelessness, which is about 6% of total cases. In addition, we now have 3 total cases identified in the jail system. At this time, there's no evidence of spread of monkeypox in shelters, encampments, or our jail system. A total of 84 individuals, or 4% of our cases, have been hospitalized with monkeypox. We continue to see disparities with the highest rates of infection among Black or African American residents, among those in healthy places index quartile 1, or our least healthy communities, and in service planning area 4, which covers Metro Los Angeles. Next slide, please. As shared for the past several weeks, here is an update on trends in new monkeypox cases. This slide shows the latest epidemiological or epi curve for monkeypox cases by episode date. As a reminder, daily case numbers are shown by the blue bars, and the 7-day average cases are shown by the dark pink trend line. As you can see, the steady downward trend in our 7-day new case average that started in the 3rd week of August has continued, and the 7-day daily average has declined from a peak of about 41 daily cases on August 20th to 12 daily cases on September 17th. This decline in new cases is consistent with global and national trends. CDC recently announced that they are cautiously optimistic about these recent declines, and we are likewise encouraged by the trends in LA County. Next slide, please. Vaccination remains one of the strategies that's critical to our monkeypox control efforts. We have now received 8,260 additional vials as a part of our Tranche 3, the final tranche of Phase 4 allocations. This brings us to 73,844 total vials of the Jynneos vaccine, which we estimate equates to about 196,000 total doses. As of yesterday, 51,701 vials, or 93,798 doses of Jynneos vaccine have been administered. Of doses administered, approximately 73% are first doses and about 27% are second doses. Increasing steadily each week, currently 51% of individuals in LA County who are due for their second dose of the monkeypox vaccine have received it. Next slide, please. I want to share some encouraging data that the CDC published yesterday that looks at monkeypox case rates from 32 state and territorial jurisdictions across the county by first dose vaccination status. They analyzed case rates among males 18 to 49 years of age who are eligible for vaccination. Cases categorized as unvaccinated had no evidence of vaccination in case interviews or immunization records. And cases categorized as vaccinated reported symptoms 14 days or more after receiving their first dose of the vaccine. People vaccinated for smallpox before 2022 were excluded. Here you see that over 4 weeks from the end of July to the beginning of September, the case rate for the vaccinated group, shown in blue, remains below 50 cases per 100,000, and the unvaccinated group, shown in pink, has substantially higher case rates between 200 and 300 cases per 100,000. Based on this data, CDC concluded that unvaccinated people have 14 times the risk of monkeypox disease compared to people who were vaccinated with 1 dose of the Jynneos vaccine. Of note, this data does not take the place of vaccine effectiveness studies that are done under controlled circumstances, and there may be confounders such as differences in behaviors and health factors that may be contributing to the findings. Nevertheless, it does provide support for the vaccine's performance in real-world settings. It also supports that there is initial protection after a single dose of Jynneos vaccine, but the durability of protection is unknown, so to achieve maximum benefit, it is still recommended to complete the 2-dose series. Given this promising data, we are expressing urgency to all of our vaccinating providers, especially our larger healthcare systems, to offer vaccination to their at-risk patients. Next slide, please. CDC also announced yesterday that they are expanding eligibility to shift to a pre-exposure prophylaxis strategy that targets persons who may be at future risk for disease. As you may recall, LA County made this shift a few weeks ago, but at this time we are revising our eligibility to closely align with CDC's newly recommended eligibility groups. Under our revised criteria, monkeypox vaccine will continue to be available to residents who self-attest to being in any of the previous 4 eligible groups as listed on the slide. In addition, monkeypox vaccinations are now available to sexual partners of people in any of the above groups and people who anticipate being in any of the above groups. These broader criteria allow us to protect more people who are at high risk for potential exposure to monkeypox. As in the past, residents who met the prior eligibility criteria are still eligible for vaccination. In addition, we are messaging to healthcare providers about their eligibility for vaccination. Overall risk to healthcare workers remains very low, as personal protective equipment and other infection control practices have been very effective in preventing monkeypox infection. But we are aligned with CDC's recommendations to make the vaccine available for persons in select occupational groups at risk for exposure to orthopox viruses. This includes research and clinical lab personnel working with or testing for orthopox viruses, and healthcare workers who are caring for suspected or confirmed monkeypox cases. Last, CDC has also updated their clinical considerations to allow intradermal vaccine administration at additional locations other than the forearm, such as the shoulder and back. This will allow people who may be concerned about a visible vaccination mark to receive the vaccine more discreetly. Public Health is reviewing these clinical considerations and will be working with our own and community providers to implement as quickly as possible. Next slide, please. In closing, please visit our website at ph.lacounty.gov/monkeypox for information regarding monkeypox prevention, management, and treatment. You can also visit our vaccine hub on the monkeypox website for the latest vaccine eligibility criteria, information on minor consent, and links to vaccination sites throughout the county. Any resident who doesn't have access to the internet and needs information can call the Public Health Call Center at 1-833-540-0473, 7 days a week from 8 a.m. to 8:30 p.m. We appreciate you sharing today's updates and public health resources with our community. Thank you.
Go ahead and facilitate questions. We also have several sent in electronically as well. First question?
Yeah, Dr. Ferrer, if you could talk a little bit more about the particular H3N2 flu strain that's going around, the characteristics, how virulent is it? You know, I know different flu strains do different things to people. If you could talk about this one.
Yeah, I think it's a great question, and obviously, you know, looking at what just went on in Australia, I would say it's, you know, A, pretty easily transmitted for flu, and B, tends for some people to result in more severe illness. So people are getting pretty sick. We haven't seen their I haven't really looked closely at their hospitalization data. I think we just got it this morning to see, you know, what differences they may be seeing. I think the big worry is most of us haven't seen any flu for a couple of years now, and our systems may just not be well prepared for flu. And couple that with the possibility of also having another serious respiratory illness circulating. I don't think it's impossible for people to get both flu and COVID at the same time. And that could also be something we want to really protect ourselves from.
We'll go to Marla next.
Thank you. Thank you both again for the in-person. Really, really do appreciate that. I just want clarification. I know you're not surprised I'm going to ask about the close contact mask mandate.
Yep.
When answering me last week and then answering the Board of Supervisors just on Tuesday, when defending your policy, you start off by saying that you are ultimately, in fact, aligned with the state. But I'm confused because the state has a strong recommendation and you have a requirement. So can you clarify?
Yeah, and thanks, Marla. I appreciate that. This remains a concern. When I say closely aligned, I mean we're closely aligned with the science, which is really what I was talking about. There's no disagreement from anybody in public health that wearing a mask after you've had an exposure is one of the most important things you can do. Like everybody knows, and we see this reiterated time and time again in any new guidance that comes out, be it from occupational health and safety, or from CDC, or from the state, or from us, highly infectious variant. If you've had an exposure, one way to minimize transmission to others is to keep a mask on and keep a well-fitting, high-filtration mask on. I think what you're noting is the difference between making a strong recommendation and a requirement. And yes, we are not aligned on that. The state makes almost no requirements. The state or the federal government, CDC, have almost no requirements. They leave it up to locals to look at their data and decide which of those strategies are worth, turning into specific actions at the local level. So we're in terms of strongly recommending and requiring certain actions here in LA County, we're aligned on a lot. Where we're not aligned, as you just noted, is on the implementation of a strong recommendation on wearing a mask after you've had an exposure. We think it's so important, given a county of this size, that people really need to understand it as a requirement.
Okay, thank you for clarifying that.
Okay.
Okay, also to the board, in defending the mandate, you told the Board of Supervisors, quote, "We are not running around with an enforcement tool here, and we don't intend to. We have never run around with an enforcement tool." So if you have a mandate and you're not going to enforce it, what use is the mandate?
Well, one of, I think these are really important questions that get to the heart of, how we live together. We have lots of requirements in many different areas around rules that are enforced somewhat. Some are enforced very strictly and some are enforced a lot less strictly because of just the sheer volume of resources that would be needed to make sure everybody did everything they were supposed to do all of the time. What we count on is sort of a contract that we have with each other that says, these are rules that help us all live together as safely as possible, and therefore we're going to abide by them. When we talk about masking, we've never given a ticket to people who don't wear a mask. We've never really tried to ensure compliance by threatening people with going to jail because they're not wearing a mask. We've instead understood that our job is to explain to people why it's so important, and then to make it clear to people that it is so important that it's a requirement and not a recommendation, in hopes that that helps everyone understand how much depends on us all taking that particular action. So in this case, there have been times in the past where we've actually required everyone who was indoors to go ahead and put on a face covering because transmission levels were so high. Here, we're requiring that everyone who's been exposed and is going out and about close to other people to put on that face covering. I will point out that this is less about defending than explaining. And I think everyone has a right to hear from us as many times as we need to explain why we in fact feel so strongly about this. We look at this data all the time. We are troubled by the high mortality rates that are still associated with COVID.
But again, with the schools, the kids are not high risk.
The kids are, as I noted, kids are not at high risk, but what kids are able to do very easily is transmit to those who are high risk. I mean, I can just talk about my own personal family. Nobody got infected until the grandchildren brought it home, and then everybody got infected. And the grandchildren,
Including you?
no, I wasn't there.
Okay.
But nobody got, up till then, up until we were in a house, people are in a household and they live with children. And yes, the children had the mildest cases, but some of the adults did not. And so again, I want to just point out, depending on your family circumstances, for some people, it's pretty easy to be dismissive of the fact that children are infecting others because nobody in that immediate circle may be at higher risk. In other families, there are lots of people on higher risk. There are millions of people in LA County in those higher risk categories. So we just can't dismiss that.
No, and I don't think the parents are dismissing it who want the choice. I think
Yeah.
they just want, they feel dismissed by the
Yeah.
mandate, and they're saying, this is my child, I know my child the best. So that's
Right.
their stance.
And I think, with all public health issues, that tension between individual choice and protecting the public's health is what's at the heart of, I think, many of these debates. We try as much as possible, particularly now when we have so many tools, to really allow for as much choice as possible. But in places where we feel like the risk is great and the cost of the action that we can take is not that big, we ask people to take a collective action. This is one of those situations.
Can I go ahead and go to Luis?
Y la pregunta será en español para Telemundo. Por favor, doctora Ferrer, si nos puede hablar sobre la temporada de influenza. Sabemos que está llegando y se espera que sea un poco más fuerte. ¿Por qué es importante vacunarse? Y no solamente para las personas de alto riesgo, sino también para los niños que usted comentaba que pueden propagarlo.
Muchas gracias por la pregunta. Con la influenza, bien similar como el COVID, bien importante que nosotros todos nos vacunamos. La cosa con los niños es que aunque ellos quizás no se enferman mucho, ellos de veramente en la familia son la gente que van a dar este virus a otra gente en la familia. Ustedes todos saben que con los niños, especialmente los chiquitos, estamos allí cerquita, atendiendo a lo que necesitan, y estar tan cerca con los niños chiquitos es bien fácil que esos virus se van de los chiquitos hasta los de más años, de altos edad, y esas son la gente que de veramente tienen que coger más precauciones.
¿Recomienda que las personas se vacunen contra el COVID-19 y la influenza al mismo tiempo?
Al mismo tiempo, y eso es que para nosotros eso será el más fácil, porque es una vez que tienes que ir a uno de los sitios donde tenemos las vacunas y te dan los dos. Tenemos dos brazos por esa razón, uno para la influenza y el otro para la vacuna de COVID.
Finalmente, doctora, sabemos que esta vacuna de refuerzo está muy paralela a la transmisión comunitaria que se está viendo. ¿Nos puede hablar sobre eso? Es muy similar a la subvariante que está circulando ahorita.
Sí,
Entonces,
es
brinda
exactamente similar, y por eso es la primera vez que vamos a ir a la temporada del invierno con una vacuna que yo creo va a ser un cambio para nosotros, porque está tan similar de lo que está pasando aquí en la comunidad.
Muchas gracias.
No hay de qué.
Some questions sent in from Ron Lynn at the LA Times. There's three of them. There are some reports that coronavirus levels in Boston wastewater are starting to increase. Is that a warning sign for us? Second one is, will it be safe to hold large Thanksgiving and winter indoor holidays gatherings this year with elderly people and without masks? And number three is, why do you think deaths haven't declined yet, and when do you expect them to drop?
Yeah, thanks a lot, Ron. Great questions. And we are all tracking wastewater. In part, we have to look a lot more seriously at what we're seeing in wastewater because our case numbers are likely underrepresenting what's going on in the community, given that many people are using over-the-counter tests. And in part, it's because wastewater, as you can see when we look at it, we think of it as an early alert, an early indicator, because it doesn't require somebody to necessarily feel sick and go and get tested before you're really going to get information about their status related to SARS-CoV-2. It allows us to acknowledge that there's been a lot of asymptomatic spread and people who are asymptomatic with this virus. So in some ways, this is a little bit more sophisticated, and that's why we track it here. And we've noted as well that there have been increases in cases in some of the communities on the East Coast. New Jersey, New York, I think, are reporting increases. I think, again, as we go into the colder months, particularly in those communities up in the Northeast, the northern states where they're going to go inside quicker than we are, And we all have the probability that there's been a lot of waning immunity. It's been months since many people got either infected or vaccinated with a booster. There's higher risk at us seeing these increases in cases. I think we're all prepared for some increases in cases this fall. I think we'd like that to be minimal, and we think if more people can go ahead and get protected with the new bivalent boosters, that will really help everyone try to dampen down the possibility of seeing a very big surge. In terms of, I'm going to go to deaths declining, I'll come back to holidays at the end. In terms of why we're not seeing deaths declining, you know, transmission is still pretty high. It's not classified as high. It is considered substantial if we were using sort of our old measuring tools, our old metrics. We still have a lot of transmission. And we have, unfortunately, here in LA County, we have a lot of folks who fall into that vulnerable category. You know, we have 1.3 million people, I think, that are 65 and older. We have 1.5 million people that are still unvaccinated, and we have millions of people with underlying health conditions. And that doesn't change. So their risk is always elevated for having a serious outcome. So as long as you've got a fair amount of transmission, vulnerable people are going to remain pretty vulnerable. I think our best hope for being able to really reduce the number of people that are passing away from COVID is we have to get transmission down even lower than where it is. And in terms of the last question, you know, what should people plan for the holidays? One thing I can say for certain is people should plan on being able to get together with the people that they love. I think depending on the circumstances in your family, depends on what layers of protection you're going to want to ensure you're using. For folks who are getting together with older people, with people who are vulnerable, have underlying health conditions, are immunocompromised, aren't vaccinated, you're still, since here we are in LA County, you're still going to want to try to do that outside, where you've got a lot of sort of natural ventilation. If you are going inside, our recommendation always with people at higher risk is to consider two things. One is making sure every single person is getting tested day of event, so that you are minimizing the possibility that somebody is coming to your indoor gathering already infected. Maybe not knowing it, having no symptoms, but actually testing positive. And that test is fairly accurate, and that will catch a bunch of people who, in fact, you would rather not have at that gathering. The second thing is for those people most vulnerable when they're indoors, they might feel safer if they do keep their high quality, well-fitting, high filtration mask on, because it does layer in protections. But I do want to note, we should all take advantage of the fact that we can be together with the people we love this holiday. We're just going to have to be careful if there are people that we're gathering with that are at higher risk. The caveat here is we should all be paying attention to what's going on with transmission. If transmission is super high, you're going to want to layer in more protections. We've got tools. You know, this is the time we urge you to get vaccinated now so you're fully protected before the holidays. And again, we urge people to go ahead and get those free test kits that you're eligible for if you're insured, and be prepared to organize a holiday, keeping in mind the most vulnerable people that are going to be at your gathering.
We have,
Go ahead.
go Marlon.
No, go ahead.
Okay, Jackie Fortier from KPCC, and then we'll go to Marlon. I've heard, this is a question about monkeypox for Dr. Singhal. I've heard some vaccine eligible people are startled by the questions they're asked to answer, including about sexual history, drug and alcohol use, and HIV status. Some people are not getting vaccinated because they don't want to answer these questions. With eligibility opening up as more Jynneos vaccine becomes available, why are these questions necessary, and what do you do with the information? Also, when will the Jynneos vaccine be available to anyone who wants it?
So that's a very good question. So I want to clarify this very clearly. So I think I said it in my remarks today. In order to be eligible for the Jynneos vaccine, you can self-attest to being part of one of those eligible groups. You do not need to bring or say anything at your vaccination visit to say that you're part of one of those groups and which one. The one thing that I think catches my attention with these specific questions that are being asked is that if you have a patient who's going in to see a doctor as part of a primary care visit, then these are questions that are asked as part of that full visit and as a full medical history that's taken. So if it's in the context of that, then it's broader than just getting the vaccine, really looking at their health overall. And it may be questions that are being asked in that context. But if these are questions that are being asked at a standalone vaccination site, then that is definitely something that we can look into because those are not required questions. If someone is being asked those questions, they can refuse to answer. We have very few actual questions that we do ask that are required by state and federal government, which is just basically some demographics so we can track who's getting vaccinated.
I have one monkeypox question about the healthcare workers who are eligible. So does that include those who are giving the vaccine?
So that's a good question. So the way that CDC had, their terminology is really for those that are caring for a monkeypox case. So those that are coming in to get vaccinated are not monkeypox cases. So we're assuming that they do not actually have monkeypox when they come in. So if they're vaccinators alone, then they would not qualify. But if they also take care of anybody with monkeypox doing testing, any sort of diagnostic work, or providing treatment or any other care, then they would. And I do also want to clarify, when we talk about healthcare workers, we're talking about the providers as well as others that are working in the clinical setting that are helping to take care of anybody who's cleaning, our nursing staff, all of the other ancillary staff that come along with our clinical providers and that participate in the care of the patient.
Okay, very good. And then my follow-up about the enforcement tool. I am confused because there are inspection teams that go out to restaurants and businesses and even schools and have cited them for being in violation of your health officer order. There's an entire page on your website that has that. So can you?
The citations that happen for a business, for example, are being non-compliant with the rules for your employees, not for your patrons. The same thing at schools. So there are rules at schools that are specific to employees and specific to, it's very rare that we've cited a school. So let's just say, for schools, it's been really rare, and it's usually associated with schools that have publicly declared that they're gonna be out of compliance with the public health orders in their totality. And many of those few situations that happened a long time ago. What I was talking about is, sort of when we had a health officer order in place that actually required people to wear their masks indoors at all public places, if there were patrons or customers at stores that weren't wearing their masks, they were not cited. We didn't ask the stores to be enforcers either. I mean, we asked them to make sure people knew what they were supposed to do. They were not cited as individuals, and the site was not cited because the customers were not wearing their masks.
So to be clear, are there LA County Department of Public Health inspection teams going to various schools to make sure that they are following the close contact mask mandate?
No, at this point there aren't. Our teams that are working with the schools are going to schools to help with outbreak management. We don't really have any teams that are going to schools.
So it's easy if the school district wants to, or quietly just say, we're not gonna follow it. It's easy for them to not.
Yes, I think it's easy in the sense that we're not necessarily there to ensure that there's compliance. I will say that there are usually teachers and staff and other students and other families that are looking for there to be compliance with sensible rules. So again, I think that's part of the social contract.
Any final questions?
Thank you, thank you.
Thank you, everyone.
Thanks a lot, everyone.
Thank you.
Just one note, like sort of moving forward, we will cut down to one sort of open presentation a week with the media present. So there are some weeks where we will be presenting in front of the board, and as you know, now that the board is back in session and the public is invited and the media is invited, if on a Tuesday we are making a presentation at the board, that'll be the weekly media briefing. We're not gonna do two, one on a Tuesday and then another one on a Thursday, unless there's a reason. You know, something changes, people need to have access to us, of course, we're gonna make sure we're available. But in general, we will either be talking with the media at our board meetings, because we're presenting to the board, and then we'll be available afterwards if you need to ask us questions, we'll make ourselves available.
Got it.
Or we'll be doing a Thursday briefing because we haven't been presenting to the board that week. So just, you know, while things are relatively quiet and there's not a lot of changes being made, I think this is sensible for all of us.
Got it, thank you.
But you always know you can get hold of us anytime during the week.